Good evening. My name is Andrew Jones. I'm the Vice President of Sales and for the US and Canada for LKC Technologies. Thank you very much for joining us this evening. Tonight's webinar is going to be on the GoToWebinar platform, and so we're going to use the question functionality from that platform. So if you have a question, if you could open up the question box, type in your question and press send. And then I will pose the questions to Dr. Ferrucci at appropriate times. Dr. Ferrucci is going to stop several times during the presentation for questions. So I have the pleasure of introducing Dr. Stephen Ferrucci. Dr. Ferrucci is currently the Chief of Optometry at the Sepulveda VA Ambulatory Care Center and Nursing Home in California. He's the Residency Director at this site and a professor at the Southern California College of Optometry, Marshall B. Ketchum University. Dr. Ferrucci has lectured and published extensively with a special interest in diabetes, diabetic eye disease, AMD, OCT, and fluorescein angiography. He is a fellow of both the American Academy of Optometry and the Optometric Retinal Society, as well as the past president of the ORS. So without further ado, I'd like to thank Dr. Ferrucci for joining us this evening and hand things off to him.
Thanks so much, Andy. Andy, can you hear me okay?
Everything's great. Thank you.
Thank you so much, Andy, for that introduction, and happy to be here with everyone tonight. And before I get started, just a couple disclosures. There's a couple different companies that I work with in various capacities, obviously, one of which is LKC Technologies that's, having the program tonight. So this is actually the hospital that I work at out here in Southern California, and just a little shot of the hospital. It probably looks better in the picture than it does in real life, I'll be honest with you. So tonight I want to talk about when to refer out best management practices for diabetic retinopathy. And, probably many of us know from a structural standpoint when we should consider sending out patients with diabetic retinopathy for further treatment. But tonight I'm going to put a little spin on it and talk about functional and talk about when we should functionally and what functional tests we can use to help us figure out when we want to refer patients out. So it's a little bit different, perhaps, than what I've talked to people about in the past. But this example of a patient here that has severe non-proliferative diabetic retinopathy, and I think you can see that he has quite a bit of hemorrhages. He's got some ermas and that sort of thing. And if you remember back from our days in school, these patients with severe NPDR, this is the old 4-2-1 rule, hemorrhages in all 4 quadrants, venous beading in 2 or more quadrants, or marked ERMA in 1 quadrant. I think there you can appreciate that. And newer studies with anti-VEGF agents are telling us that this is an appropriate time to refer patients over to the retinal specialist to at least consider treatment with serial anti-VEGF agents, because that will help out the health of the retina and prevent bad things from happening. Here, there's an example of a patient with proliferative diabetic retinopathy, and I think you can appreciate some neovascularization, right up here, and you can see that right there. And keep in mind too, was talking about function. This patient very likely is 20/20. So using acuity is very often misleading, because this is a patient that could be 20/20, but still has significant retinal damage, and again would need a referral. And here's a patient. Here's a patient with clinically significant what we used to call clinically significant macular edema. Now we're really calling it center-involved diabetic macular edema. And here you can see a patient that has center-involved diabetic macular edema. And again, this is going to warrant a referral over to our retinal specialist. Here it is again. But again, keep in mind that these are all structural things, right? And very often, functional tests and structural tests and functional and structural integrity do not go hand in hand. So what I want to talk to you about tonight is how we can use ERG in order to look at the function of the retina, which might help precipitate sooner and better referrals in our diabetic patients. Now, when Andy first talked to me about ERG, I said, what are you talking about? Like, the ERG it's a huge unit. You have to take up a whole room and this sort of thing. I don't have room for this, right? But this is not what we learned about in school, to be honest with you. This is now a handheld machine that does electroretinography in a way that is unprecedented, quite frankly. So it measures the electrical responses of various cell types in the retina, including the photoreceptors, that's the rods and cones, inner retinal cells, bipolar and amacrine cells, and the ganglion cells in response to a stimulus. Now, we're going to talk mainly about diabetic retinopathy tonight, because that's really my passion: diabetic disease, macular degeneration, retinal disease. And for that, you really look at the photoreceptors in retinal cells, but also it has great use in ganglion cells, which is more helpful probably when you're following patients with glaucoma. So I'll touch on that briefly in some of the cases, but that's not going to be my main focus tonight. So how does it work? Well, in a nutshell, and we don't need to get into this super deep, but light comes into the eye, and then that light hits the retina, it travels through the retina. And the amount of time that it takes to get through the retina, that's called the A wave. And this is the photoreceptor function driven primarily by the cones and the bipolar cells, okay? Then it kind of bounces off the retina and back up, and that's the B wave. And this is the bipolar cell function, which inverts the signal from photoreceptors and transmits to the inner retina. And then the images continues to go through the retina, and the PhNR is the innermost retinal layers in the retinal ganglion cells. And the PhNR is most useful for glaucoma, when we start to look at glaucomatous damage and that sort of thing. And then the A wave and the B wave are what we're really going to be looking at when we start to think about retinal disease and diabetic retinopathy. So like I said, the cool thing about the RETeval, it's a handheld full ERG device that has multiple uses and multiple tests on the one unit. It's handheld, it's completely portable. You can take it from exam room to exam room. Non-mydriatic, you can do it without dilating the patient. As a matter of fact, when we talk about the Diabetic Retina Assessment Score, you actually don't want to dilate the patient because pupil response is an important factor in that algorithm. You just simply have some sensor strips that you connect to the patient, and then you connect those sensor strip electrodes into the RETeval. It takes a couple minutes depending on which program you're running. Simple user interface. It really interfaces with virtually, as far as I know, any type of camera or camera system you have. Mine, I have just hooked up to my laptop. Normative database. That's important. You always want to know what normal is so that you know what abnormal is, right? And you really can't know abnormal unless you know normal. So you need that normative database. And it's color-coded reporting, sort of like a lot of other instruments we have, right? In OCT, if you see red, that means it's something bad. It's very similar with this. It's color-coded to really make it a little easier to digest. Easily integrates into practice workflow because, again, it's portable. It's easy to use. You can just do it in a couple minutes at any time, really, whatever works best for your particular practice. Fixation is not required and works with media opacity, so cataracts or corneal issues don't really make a big difference, to be honest. So this is sort of what it looks like. You just have this little docking station, which actually has two functions, really. It charges the unit, as well as there's a cord that's not shown here that then goes into your computer too, and it will also transmit the tests from the handheld unit into your computer as well. So the docking station has two separate functions. And then the patient, this is sort of the patient view. The patient, there's a sort of an eye cup that goes over the patient. They sort of look in there and they just look at the little fixation light there, right here. And this is kind of what the patient, what you see when you look at the patient. You put on these little sensor strips underneath the eye. That's probably the biggest rate limiting step, just making sure you get those positioned just right. And after you do a few, it's relatively easy. And then this is the view that the tech or yourself, if you do it yourself, I generally have my techs or my residents do it. This is what they see. And again, you want to have the patient look at this dot if they can, but if they can't, really you can just have them look straight ahead, and you can just keep their pupil inside that green circle. And as long as you keep it centered within that green circle, and even I would say reasonably centered within that green circle, you'll get good test results. So, as I mentioned, I'm mostly interested in retinal disease, whether it's diabetic retinopathy or AMD or what have you. And one thing that's always been one of my bones of contention is that when we think about glaucoma, we measure a lot of things, right? We measure structure, so we're going to look at photos, we're going to look at OCTs, and those are structural tests to look at the integrity of the optic nerve, right? And then we look at functional tests like a visual field. And we know that in glaucoma, very often structure and function do not go hand in hand. Sometimes patients have functional loss before you start to see structural loss, right? But for a long time with diabetic retinopathy, we really only had structural tests. We could do photos, we could do an OCT, and obviously we're going to do our clinical exam and look at the retina, but that's still all structural. Wouldn't it be nice if we had a functional test in order to look at the functional health of the retina? Because again, we know that function does not always coincide 100% with structure. So if we know both structure and function, I think we can do a better job taking care of our patients and following our patients with diabetic retinopathy. You can also use the ERG for early diagnosis as well, because before you start to see, again, structural damage, you'll start to see some functional damage in the ERG as well. So you can use it for following these patients, deciding when to refer them, and also diagnosing any issues sooner. The nice thing is when we think about visual acuity, right, and we think about visual acuity as a sort of a signal of retinal health, but it's really not. It's really only a signal or a test of macular health, right? And we've all seen those patients that have significant diabetic retinopathy, but have perfect 20/20 vision because that retinopathy is not in their macula. So by just checking the visual acuity as a functional test, we're really missing the full picture. A pattern ERG does about the same area rather that a 24-2 visual field would do. So it's better. You're getting a bigger slice of the retina, so you're able to see the health of a bigger part of the retina. But when we do a full field ERG like we do with the RETeval, you're really getting a really good picture of what the overall retinal health is. Not just the macula, not just the nerve, right? You're getting a picture of the entire retina. And we know now that we're starting to do wide field images and all this stuff that a lot of the damage from diabetes happens in the periphery. So if we're not taking into account the periphery, we're really not taking into account the level of diabetic retinopathy. It's interesting, there was a study that came out not that long ago, and it said if you don't look in the periphery, right, if you just look in the posterior pole of patients with diabetes, and this is structurally, you're miscalculating the level of retinopathy in at least 10% of patients. So in order to get a proper feel for their level of retinopathy and disease, you really, really need to look in the periphery. So the full field ERG takes the periphery and the entire retina into account, not just the macula, not just even the posterior pole, but the entire macula. So way back in 1987, some smart people started to look at ERGs, and what they noticed as the diabetic retinopathy progressed, they started to see very typical changes in the ERG. And there's been multiple publications using the RETeval device to show these changes in ERG and how it correlated with progression in diabetic retinopathy. So you can see here in this picture here, increased disease severity. So as we start from left to right, I think that's left to right. I've always had problems with the difference between right and left, and then becoming an optometrist and the patient's left is my right and my right is their left. I get so confused. I'm really bad. My wife will tell me, go down here and make a left. And I go, left. And she goes, yeah, that way, because I get really confused. It's really quite sad. But I digress. You can see here on the left with no diabetic retinopathy, that's a nice healthy ERG. You can see the amplitudes, right? That's how strong the signal is. You can see how nice and tall those are with a nice robust image. And then as we go from over to mild and then eventually moderate, severe, and proliferative diabetic retinopathy, you can see how this amplitude is shrinking. You're not getting as much signal because the retina is actually becoming damaged. So again, we know that the ERG gets affected as the level of retinopathy gets worse. So the thing that I use most, and again, on the RETeval, there's many different programs you can use. There's some for glaucoma. There's this one we're going to talk about for diabetic retinopathy assessment, but there's a bunch of different programs. And you can get as deep into the ERGs or not as deep into the ERGs, you know, depending how much you want to use it for a variety of retinal diseases. But you know, the main thing I use it for, to be honest, is this, the DR Assessment Protocol. And what it does is you do this test, this DR Assessment Protocol, and it simply gives you one number. And it uses 4 different components to come up with this number. It uses the implicit time, right? So how long it takes a signal to get in and out of the retina, if you will. Amplitudes, how strong the signal is in the retina. The pupillary response, that's why I said you don't want to dilate patients for this, because it uses the pupillary response, because we do know as patients get retinopathy and diabetic damage, their pupils don't respond as well. That's why sometimes, you know, your last patient's a day, a diabetic patient, you want to get going home, you try to dilate the patient and they just don't dilate well. It's really irritating sometimes. And age. Patient's age. So it uses these 4 things into an algorithm to come up with one single number. And what they found in studies is the increasing scores indicate increasing disease severity. So as that number gets higher, so too is the amount of damage to the retina. So you can use that number to follow the patient over time. And if you see that number increasing, this is a patient that's having more damage. But the really cool thing is they've done studies and they find that the number 23.4 is sort of the magic number, if you will. And what they found in these studies, that if the DR score is greater than 23.4, the patient has an 11 times increased risk of needing an ocular intervention within the next 3 years. That would be laser or anti-VEGF or something like that. So 23.4, 11 times increased risk of needing an ocular intervention within 3 years. So if I do this test and I come up with a patient who's 23.4 or more, you know, that's a patient that I'm really going to strongly think about sending out to my retinal specialist to get some further tests. And a lot of these patients, what happens is, even if their retina doesn't look so bad, when you come up with a score like that, the retinal specialist sees them and does a wide field fluorescein, they find they have a lot of peripheral ischemia that wasn't evident on clinical exam. So 23.4, keep that number in mind. There was another study done that I thought was actually pretty interesting. And what it did, it looked at what they called high-risk patients. And these patients had either severe NPDR or PDR on their retinal exam and a DR score greater than 23.4. And what they found was if they just looked at the photos alone, they could detect which patients went on to need an intervention within the next 3 years in about 22%, about 22% of the time they were correct in these patients. But if they used the RETeval, they were about 35% correct, determining which patients were going to need interventions. But if they used both, and which is a 60% improvement, which is pretty solid. But if they use both, the photos and the RETeval, they were able to predict about 70% of the time who needed intervention. So what I like to do is I don't like to use the RETeval in a vacuum. I don't like to use what their retina looks like in a vacuum, but you use the both together, structure and function, to get a better picture of what's going on with their retinal health. So the two together are better than either apart. One might argue that the RETeval is a little more sensitive to look for changes than even photos, but together, to me, is where you really get the full benefit. So, you know, this is sort of how you interpret it, and you want to look at implicit times and amplitudes. And again, it's color-coded, so anytime you see red, that means that there's a really strong chance that something is amiss. It's like a 97.5% chance or more that's abnormal. So there's 2 things, slow implicit times and amplitudes. And slow implicit times are usually indicative of cellular stress. So a lot of the times you'll start to see decreases in implicit time before you actually start to see any disease. So very often it indicates sort of a retina in stress, and you'll start to get slower implicit times. And then amplitudes, when the amplitude, right, that little wave like that, when that amplitude starts to get decreased, by that point, usually you'll start to see some damage. However, sometimes the amplitudes, quite frankly, can relay more damage on a functional level than you would think just by looking at the structure of that eye. So this is sort of an example of a test that we do on a patient. I'm going to do the DR assessment on this particular patient, and it's pretty easy to read. You can see here, it comes up here, the DR score is 14.8, and it tells you right underneath it's green, right? And just like with OCTs or other things, you know, green is good, red is generally bad, yellow is caution, right? So here we see the DR score is 14.8. It says right there, right under, within normal, within limits. You can see here it shows that the patient is nice and centered. So if you see this like with a patient way off center, you know perhaps you can't put too much stock in the images, right? And then if you look down here, the implicit times and the amplitudes of both eyes, here's the right eye here, here's a left eye here, and then here's a pupil response down here, right eye, left eye. You can see everything's in green. So everything's green. So this is a patient that's actually doing quite well. And this is a patient that you know, you can continue to follow unless there's other circumstances going on. This is an example of a patient that has an abnormal DR assessment. So you can see that the DR score is 24.8. Remember, I told you the magic number was 24.3. So it's not a lot higher, but it's higher. So DR score is 24.8. And then it tells you right here, outside limits. And instantly, right, it's color coded. So instantly you see all these reds and you go, oh, geez, you know, this is not great. So you can see here on the right eye, the times are starting to get affected, but the amplitudes, I mean, they're lower, right? 35, 38%, 31, 37%. So they're being decreased, but the amplitudes are still normal, but the implicit times are starting to become affected because, again, when the eye starts to get stressed out, you generally, with diabetes, see defects in the implicit times before it starts to show up as much in the amplitudes. And we can see down here in both eyes, the pupils in both eyes are fine. So 24.8, 24.3 is our number. So we're concerned about that. So we're going to go ahead and, you know, either have this patient come back very, very soon to see them again and see if that number is even getting worse, or we're going to refer this patient out for further treatment. This example of patient, like I said, I don't use it as much for glaucoma. I'm more of a retina guy. I know that sounds like a cop-out, but I'm more of a retina guy. I enjoy it for the retinal health, particularly the diabetic retinopathy, but it does have some nice uses in glaucoma as well. And in glaucoma, rather than the you know, the amplitudes and the A waves and the B waves I was just telling you about, there's this PhNR that you want to use in these patients. So you want to look at the implicit time, the wave, and then the W ratio, which I always get this wrong, is one of these numbers divided by the other one or something like that. And I always forget which is divided by which, but it doesn't particularly matter. So you want to look at the numbers in the PhNR. And again, you can see in this patient down here, everything's green. This is a patient that's doing, you know, quite well. And this is a patient that's probably, you know, stable and is doing okay, and the treatment that you're doing is perfectly fine. Here's a patient that has an abnormal PhNR, especially in this right eye, and you can see that, you know, we've got some problems here as well. And then over here in the PhNR, you can see everything in this right eye pretty much is thrown out of whack. And in the left eye, even though these PhNRs are normal, you're starting to see some changes in the B wave. So again, you know, this is a patient probably is going to need some sort of an intervention in the right eye, whether it's you know, an additional drop or something like that to get better IOP control, or perhaps a referral for, laser or what have you. And then this left eye, is an eye that's might be doing okay, but I'm going to keep a close eye on this eye, no pun intended, because I'm concerned that maybe it's gonna go in the bad direction like the fellow eye. So you can use this PhNR in order to follow your glaucoma patients. So I think I'm going to show you a couple cases, but before I do that, Andy, do you have any questions for me?
I do. Yeah, thanks, Dr. Ferrucci. So one of the questions is about reimbursement, and I know that we'll be covering that later on, so I'll just let the attendee know that we'll cover it later on.
Yeah, I always tell people I'm not an expert in coding or billing. I will defer that at the end to Andy to answer.
One of the questions was around the age range for the normative data, so I can kind of share that. So it goes from 6 months of age to 94 years of age. So it's fairly wide in terms of the range of normative data. Another question was, and I get this question a lot too, is, yes, you can detect diabetic retinopathy risk of progression earlier, especially early on in a patient who's very early in the disease process. What do you do with that patient? I mean, obviously you probably don't refer that patient out, but what's your strategies with those patients?
No, that's a great question. So if I see a patient that, I do the RETeval and I feel like, he's kind of moving in the wrong direction, but he's not super bad, right? Patient education, use that patient education, right? You say, hey, listen, I have this device, it's showing that there's some damage going on with your retina. And if you don't maybe get your blood sugar under better control, right? Or maybe take better care of yourself or what have you, we might run into problems down the road. So this is a really good opportunity to talk about patient education, good A1C control, good blood pressure control, right? Because we know that both blood pressure and blood sugar are risk factors for either getting retinopathy or if you have retinopathy, having that retinopathy progress. So it's a great time to, have that discussion with a patient. And also, hopefully, send a letter over to their primary care doctor or their endocrinologist, who's ever following them, and explain to them, hey, I did this test. It shows that they're starting to have some damage to the retina. Please, let's work together to get this patient under better control so we can prevent something really bad from happening. So that's how I use it.
There's another question. So, thanks, Dr. Ferrucci. There's another question. If you have a patient whose pupil reaction is compromised in some way, is there another test that you can use that's not a DR assessment that can help with those patients?
Oh, that's a good question. I have not. I'm right. So yeah, so I've not personally run into that, like a patient that let's say they had some sort of an injury and they have a pupil, injury to that eye. I mean, I would do the other eye that has a normal pupil. If they have two abnormal pupils, I don't know. I've not run into that situation. I'll be honest with you. Do you have an answer to that, Andy? I've not run into that.
Yeah. So there is another test that doesn't have the pupil response in it. It's the Flicker 16 Trollin test, and it's basically a 30 hertz flashing that is part of what's in the DR assessment, and it still gives you the implicit time. It still gives you the amplitude, and it will flag anything that's abnormal. That can be particularly helpful also in patients who maybe only have vision in one eye, because the DR assessment, it relies on both measurements from both eyes. So if you have a patient who can only see in one eye or vision is very compromised in one eye, I would use the Flicker 16 Trollin test.
Yeah, see, I learn something every time I do this, and I learn from people asking me questions, but that's how we learn, right? Not just from, someone talking like me, but we learn from each other. So that's great. That's good information. But if you do that Flicker thing, it doesn't give you that one DR score. So then you'd have to look at the exact amplitudes and implicit times then, correct?
Yes, absolutely.
Yeah. Cool. Yeah, cool. That's good information. Thank you.
No problem. My pleasure. That's it for questions so far. So if you want to keep going, that'd be great.
So let's jump into a couple of cases. And again, if you have questions, please feel free to ask me, and I'll get Andy to answer them for me, apparently. So here's a case. First one's an example of a patient with a diabetic retinopathy. So 40-year-old white female, type 2 diabetes for about 5 years, as well as concurrent hypertension, medication, currently taking metformin, which is a very popular medication used, obviously, for diabetes. Last time A1C is 6.8, and you'll keep in mind, in a perfect world, we'd like our patients with diabetes to have an A1C less than 7. In an imperfect world, we can sometimes live, especially in older patients, if it's less than 8. Kids, you know, if you have a kid with type 1 diabetes, they often give them a little bit more leeway with the A1C. But 6.8 seems like that's in relatively good control. We look at the patient's retinal photos here, some retinal images here, and really it looks pretty good. They're really, on clinical exam, it does not look like there's any diabetic retinopathy. Perhaps there's some tortuosity from the patient's high blood pressure. So it wouldn't be a bad idea if you could check the patient's blood pressure in office to do that as well. But as far as the diabetic retinopathy, they look pretty good. And I'm going to do my DR assessment test on this patient. And here you can see the DR score is 12.5, which is actually, you know, pretty darn good, to be honest with you. And then if you look here, within normal limits, and then if we look down here at the right eye, the times, as well as the amplitude, left eye times amplitude, as well as the pupil, you can see that everything's nice and green, everything's within normal limits. So this is a patient that's doing very well. So by looking at the retina looks great. Structurally, functionally, the retina looks great. So this is a patient that I'm pretty and they're in their pretty good control. It's a patient I'm pretty comfortable just giving them a little patient education, having them come back again to see me next year. And I think next year, when I see the patient, I'll dilate the patient like I do. I'll snap some more photos. I'm a big fan taking photos, because I think sometimes, especially with the wide field images, you know, you see things in the photo that maybe you even miss on clinical exam. You know, the patient's moving their eyes around and squinting. Gives you a nice image. And then I'm going to repeat this again next year. I'm going to keep an eye on this number, 12.5. And if I see them again next year and it's, you know, 12.5 or 12.7 or, you know, whatever, 13 even, right? I know this is a patient that's still in pretty good shape. If I see him next year and suddenly his 12.5 shoots up to, you know, 20 something, then I know that something's going on in this patient. They're taking a turn for the worse, and I need to think about what my next step is going to be. So here's another example, a second case here. Were there any questions on that case at all, Andy?
No questions on that case.
Fantastic, fantastic. So like I said, if you have any questions, please feel free to ask me. So here's another one. Here's another case here, and this is a 53-year-old white male, type 1 diabetes for about 20 years and a little bit of high cholesterol as well. And it's been a patient that's been seen before, and they did have previously just a touch of mild non-proliferative PDR, non-proliferative diabetic retinopathy, for about 5 years that we've been following the patient. Hemoglobin A1C, also not bad, 6.9 with good vision. And when we do the photos, again, and I highlighted it with these arrows because I wasn't sure you'd be able to really see it, but there are some tiny hemorrhages. There's some dot blood hemorrhages. But honestly, overall, this retina looks pretty good, especially for a patient that's had type 1 diabetes, not type 2, type 1 for 20 years. The studies tell us that patients who have type 1 diabetes for 20 years or more, about 90, I believe the number is 95% or some, are supposed to have some level of retinopathy. And of those, about 50% or more are going to be proliferative diabetic retinopathy. So when you have a patient that's had especially type 1, but even type 2 for 20 years, you really should expect to see some level of damage in these patients. And I would argue that this level of damage structurally is actually pretty darn good for a patient that's had that history of diabetes. Here's the OCT, that looks fine as well. So we're going to do our diabetic retinopathy assessment score. And when you look at this patient, DR score is 22.1. Remember, 23.4. Every now and then I have dyslexia, I swear to God. You know, is 23.4 is the number, our magic number, right? 23.4. So 22.1. So we're not there, but we're not that far away from it. But it still flags it as within normal limits. And when you look through it, the right eye looks great. It's all green. You can see that the amplitudes, the amplitudes over here and the implicit times are fine. the pupil's fine. But when we look at the left eye, right, the implicit times are starting to become deficient. And this is with the 32 flicker, and this is the 16 flicker. The 32's, outside of the normal range, 98%. This one's 97%, so it's almost there, to be honest with you. So the implicit times are starting to become damaged in that left eye, and you can see down here too, the pupils is a little bit affected as well. So this is a patient that even though the retina looks pretty good, I'm concerned about this left eye. So this is an eye that I'm going to follow a little more closely. I'm not going to tell the patient, oh, you have very mild diabetic retinopathy, come back and see me in a year. I'm either going to see this patient back sooner, maybe 3 months, maybe 6 months, repeat the fundus exam, and then repeat the DR score, especially in that left eye. Or if I'm really concerned, this is a patient that if I were to send over to the retinal specialist, it wouldn't shock me if they did a wide field fluorescein on that left eye and found a lot of peripheral ischemia that indicates more widespread damage than it would look like on clinical exam. So again, even though, and just it's the same thing on everything, OCT or visual field or anything. Every now and then, even though it says within normal limits, you've got to do a little deeper dive. And when you see these yellow and red numbers, that's a caution sign. So here's another patient, and again, I don't use it. Oh, this is a diabetic patient. So this is, I thought it was the glaucoma patient. So this is a patient, 41-year-old female, has had type 2 diabetes for a long time. You can see that the medications they're on, and the right eye has poor vision from a vitreous hemorrhage associated with a proliferative diabetic retinopathy. And the left eye also has some proliferative diabetic retinopathy, but actually has relatively good vision. So this is in 2018, and this is not my case because I've not had the RETeval since 2018. So this was given to me by a colleague of mine. But you can see the DR assessment is 28.8, and you can see how flat that amplitude is in both right and left eye. Right eye more so than the left eye. But this is a patient that has significant damage. So the implicit times are affected, as are the amplitudes. And then the patient goes on to have, just a little bit of laser. And I'm obviously being facetious because quite a bit of laser, in this particular patient. So they have had all this laser, and their vision actually is better. And when we do we're going to check their DR assessment, and it's 20. This was 28.8 originally in 2018. We do in 2019, and it's actually improved. Their DR assessment 23.4 actually says normal, but that's the cusp of abnormal. But this is a patient that actually with treatment actually is better than they were pre-treatment. So it makes us feel good to know that we're helping the patient, we're doing some treatment, and that seems to be appropriate for this patient. Any questions before I move on to another case here, Andrew?
Yes. So Dr. Ferrucci, one question is, how long after diagnosis would you expect to see changes on the RETeval in a young insulin-dependent patient? For DR, changes in the retina won't show until a few years later.
Yeah, so it depends on the patient, right? I mean, every patient's a little bit different. So, and it's a lot of factors, it's their control and how long they've had the disease, and there's a lot of other factors. And then there's probably other factors that we don't understand. And we've probably all seen patients that don't do anything right. They have bad A1C and they don't take care of themselves, but they have no retinopathy. And then we see other patients that do a pretty good job taking care of themselves and have retinopathy. And probably there's some other underlying genetic something or other that we just don't know yet. So it's really hard to say, how long would you expect, any damage. The bottom line is that, the longer you have diabetes, the more likely you have to have damage. Type 1s get damaged sooner than type 2. So I would just monitor those patients. I would do the ERG as well as a dilated retinal exam with photos and OCT when indicated to follow those patients.
Thanks, Dr. Ferrucci. Another question. So I guess you kind of answered this in your case, but how often do you do the DR assessment in your diabetic patients?
Yeah, I mean, and I think it depends. It depends on how often you're going to see the patient. Now, keep in mind, I'm not an expert at coding and billing, so one advantage I have working at the VA is that I don't have to be so concerned with am I going to get reimbursed for certain tests. So it makes me perhaps practice a little bit different than you guys would. But in my opinion, every time I have the patient come back, whether it's a year for their diabetic exam, if they just have mild retinopathy, or if I have them come back in 6 months when they're moderate, or 3 or 4 months if they're more than moderate, I'm probably going to repeat the DR assessment at any chance I get, because the thing I like about it is I'm looking at a patient, I'm making a subjective guess. Ooh, they look like they're getting better. Ooh, they look like they're getting worse. But it's super subjective in a way. This gives me an objective number that I can actually use that objective number to follow the patient over time. So in a perfect world, anytime I see the patient back for the dilated retinal exam, I would do this test in a perfect world. Now, like I said, whether or not you get reimbursed for it, I don't have the foggiest clue, because I'm fortunately in a situation where I don't have to worry about such things.
Yeah, in the US, there's no limit in terms of the number of times you can do the test and the frequencies. Yeah, so that's it for questions so far.
Fantastic. So let's move on to a glaucoma case. And this was one that was also given to me by a colleague of mine, because as I mentioned, I really, I get a busy practice. I kind of have to limit how much stuff I could do sometimes. So I'm a big proponent of the diabetic one, but I just wanted to show you a case or two of diabetes so you can see that it does have some implications there. Here's a 62-year-old white male with primary open-angle glaucoma, a little worse in the left than the right. They're on Vysulta and Ropressa, both in the evening. Reports good compliance, and you can see their IOPs there, 12.3 and 16.7. And I think that's a corrected IOPs when you take into account their pachymetry, which I don't actually always do, to be honest with you, 10.8 and 9.9. And so here's their GCC and their retinal nerve fiber layer over a period of time, going all the way from 2014 all the way to 2021, so over a course of 6-7 years. And if you look at this patient, they really look pretty good. They really look pretty stable over the time. The GCC, has this small little defect, but nothing all too significant there. And then the numbers here are relatively the same. You can see they have some thinning here that kind of stays consistent, but it's really, really very similar. And when we look at the RNFL rate of change and the GCC rate of change, it really looks pretty good, to be honest with you. And here's the left eye. Like I said, the left eye has more damage than the right. So you can see in the left eye, it probably got a little bit worse, but it started out worse as well in 2014. And same thing with the retinal nerve fiber layer. It got a little bit worse. It started out worse, but did get a little worse. And you can see that the nerve fiber layer is almost the same, but there has been some degradation in the GCC. And this is a visual field of some visual field that I don't even know what kind it is, to be honest with you. But left eye, you can see they have a defect here, and the right eye looks relatively decent. And this tracks the visual field over time. Here's the left eye, here's the right eye. And again, you can see the right eye is pretty stable, and the left eye maybe has a little degradation, but it's not half bad. And then when we look at we do the RETeval, we look at the PhNR, and the right eye looks good. Everything's good. The amplitude and the time is good, and the W ratio is fine. But on the left eye, these are good, but the W ratio is a little out of whack. So this is a patient that left eye has a little more damage than the right eye. I'm going to want to keep an eye on this number, no pun intended, and make sure that number doesn't continue to go in the wrong direction. If it does, I'm going to change my treatment. I'm going to be even more aggressive in that eye. And here's the patient's eye, and you can see that the nerve here, and probably a little more cupping here. The PPA kind of makes things look a little bit different than it really is. So, and here's another example of another glaucoma patient. And this is a patient that's had cataract surgery and some other things in SLT, and They're on Rocklatan, which I love the name Rocklatan. If I ever get another dog, I'm going to name my dog Rocklatan. That's neither here nor there. And then Simbrinza as well. You can see that their pressure now is pretty good. It's still a little bit high in that left eye, but look how high it was, at one point. So, and this is a patient that you can see here on the GCC. This is a patient that's progressed quite a bit from 2010 all the way to 2021. You can see that they've really had a lot of progression in the GCC as well as the retinal nerve fiber layer. Look at all this red here that wasn't necessarily here on baseline exam. And you can see these two graphs here indicate that there certainly is a change going on. And I think the left eye to me looks even worse. And you can see the degradation, the GCC, as well as the nerve fiber layer over this period of time. Visual fields, both visual fields look bad to me, left more so than the right. And again, when we look at the plotting the changes over time from 2018 to 2021, we can see that the left eye's getting more worse or worser. I don't think worser is a word, more worse, right? And the right eye is getting worse, but not quite as bad as that eye. And again, we do the RETeval, and you can see down here the numbers, the W ratio on the right eye is a little out of whack. So it lets us know there's some problems there. But look at the left eye, right? The almost everything's out of whack. So the W ratio and the amplitudes are out of whack on that eye. So this is a patient's perhaps not doing well and is going to need a little change in treatment, a little more aggressive treatment, whether that's adding more drops or I think the patient already had an SLT. So whether it's more SLT or a trab or a filtering surgery, whatever the right thing is. But this shows you clearly that this is a patient that's having some glaucomatous damage. And it would be interesting. I don't think my colleague had this test over the whole time he saw that patient, but it would be nice to see how these numbers change with time if we do or do not treat those patients. So, that's kind of what I wanted to talk to you about tonight. I've just got a couple closing comments that I wanted to make. But before I do, Andy, are there any questions for me?
Yeah, actually, there's a couple. I think one you kind of alluded to just a second ago, and it's more diabetic retinopathy related, but have you had improvements or patients who show improvements on implicit times with treatment? Have you, I think you showed a couple of cases like that.
Yeah, so I haven't had, a heck of a lot, but some of my colleagues that have had this for longer than I've had it have reported that if the patient gets better blood sugar control or X, Y, or Z, that it can improve. I personally, haven't had a lot of that happen, but it can happen, I'm told.
And I guess this is kind of a question. So, obviously you see a lot of patients with suffering from diabetes or patients with diabetic retinopathy. Do you have any tips for managing those patients? Like how do you improve compliance? What are some of the things that you do in terms of managing those patients that you want to share with them?
Compliance in our diabetic patients is an ongoing struggle, and a couple of things you have to keep in mind is one, there was a study out not too long ago, and it said that the average patient with diabetes has 25 patient visits a year. That's the endocrinologist, the diabetologist, their eye care, their dental care, someone to look at the kidneys. So it's like everyone. So these patients very often have a lot of different appointments, and maybe we're concerned about their eyes, but maybe the patient's been told that, hey, you're having kidney problems, you might have to go into dialysis. So all these other factors can complicate them coming in to see us. So it is complicated, but the studies show that the number one reason that patients don't get their eyes checked is because they just don't think they have a reason to, because we know that patients can have perfect vision with a lot of retinal disease. So it really is important. Patient education is important. Explain to patients how diabetes can affect their eyes. Explain to them that diabetes can affect their eyes even if they think they have perfect vision. So that's why we want to see them periodically, whatever that period is, whether it's a year or 6 months, whatever is appropriate in that particular patient. But we have to stress on them that we really want to see them, accordingly, because I always explain to them that the sooner I can detect a problem, the more options we have to fix it, and the better off we are in the long run. If we wait until you start to have vision loss, it's almost too late to start fixing the problem. I tell them it's almost like they say if you're in a desert, right, and you have water and you wait till you're dying of thirst to drink the water, you're already too dehydrated and damage has already happened. You're supposed to drink the water all the time to prevent yourself from getting to that ultra thirsty stage. It's the same way with this. The sooner I can detect it, it gives us more options and a better chance for success. I hope that's helpful. I'm not sure.
Thank you so much, Dr. Ferrucci. I appreciate that. For questions, that's it so far, but well, I guess maybe we can check once again at the end.
Sure. So just a couple, thoughts in passing. I think the ERG is a good tool rather in a medical optometric practice. It gives you an objective versus a subjective measurement of diabetic retinopathy. And if you look at studies, even retinal specialists disagree on the level of diabetic retinopathy. One says it's moderate, one says it's severe and moderately severe and whatever. So even retinal specialists, as well as optometrists and general ophthalmologists, can disagree on diabetic retinopathy levels. This gives you an objective measurement, right? Subjective, no, objective, yes. I always get those two terms confused. An objective measurement, it gives you a number. You can't argue with a number, and you can then use that number to follow over time. And I would argue that you'll see changes in that DR score before you'll actually notice huge changes in the retina. So that might start to slowly get worse, but the retina looks relatively the same. You can also use it to detect cellular stress, not observable on conventional OCT of retinal photos, meaning that you'll start to see some changes in these implicit times as the retina starts to become damaged before you see frank damage. It's the same with a visual field, right? Very often you'll see changes in the visual field before you actually see changes in the nerve structure. And you can use those changes to guide your treatment, whether that's an additional medication or whether that's better patient education or a better hemoglobin A1C score or referral over to our friendly retinal specialists. It helps make clinical decisions when conventional structure and function inflow conflicts and helps them feel more comfortable in clinical decisions, right? I see a lot of patients with diabetes. I think that I do a pretty good job evaluating them for diabetic retinopathy, but there's nothing wrong with having that objective number to help me out even more. And, I think about this a lot. I wouldn't follow my glaucoma patients with just structure, right? So why would you only use structure in patients with diabetic retinopathy? We know that structure and function do not always go hand in hand. One happens before the other sometimes. So now that we can check the the functional integrity of our patients with diabetic retinopathy, why wouldn't we do that? Because by using both structure and function, we can get more intelligent and perhaps sooner referrals, especially those with functional change. And really, when you think about diabetic retinopathy treatment, we know that earlier referrals can lead to earlier treatment, which can lead to better visual outcomes. And that really is our goal with our patients with diabetic retinopathy, letting them live for as long as they possibly can with as good vision as I possibly can. So I think the RETeval can really help us take better care of our patients with diabetic retinopathy. That's really all I have for this evening. Again, I'm happy to answer any other questions if there are a couple other questions out there, Andy.
Yeah, there was a couple of questions relating to reimbursement, which I thought you were going to hand that off to me and
yes.
baton to me in terms of reimbursement. So I apologize to anybody on the call who's not in the U.S. This slide is kind of U.S. centric. The average Medicare fee for full field ERG, that's CPT code 92273. That's what the RETeval does, is $129.08. That can be higher or lower depending on which part of the country you're in, which urban versus rural. And then, I'm sorry, if you could go back one slide. The private plans actually can pay a little bit more, and a lot of states, Medicaid covers it as well, but pays a little bit less. There's 670 plus ICD-10 codes that may be associated with this CPT code. So there's a lot of diabetic codes. There's less glaucoma codes, and then there's a lot of codes related to retinal dystrophies, genetic issues, that kind of thing. So
Andy,
in the US, oh, sorry.
Could you go through all 670 codes right now, please? I'm kidding.
Well, ICD-10 codes are funny because, you've got mild non-proliferative diabetic retinopathy, right eye, left eye, both eyes,
Yeah.
and then, and then with DME, without DME. So
Just with diabetic macular edema, without diabetic macular edema, yeah, it's nuts.
Exactly. But and believe it or not, there are some AMD related codes as well that are included there. If you look at it from a billing, so the device itself costs $18,975. The sensor strips come in packages of 2, and those go for $14. When you factor in the cost of the unit and the cost of the sensor strips, oh, and by the way, when you buy a device, you get 50 sensor strip pairs to start with. But let's say you're seeing 3 patients a week. It'll take you about a year to pay off that device. If you're seeing more than that, it'll take a lot less to pay off the device. So it's fairly strong reimbursement, and with the cost of the device, it's a relatively quick payback on this device. So I know that in Canada, I'm originally from Canada. In Canada, it is covered by most provincial healthcare plans. I think in Ontario, it was around $90, and that's both the technical fee and the professional interpretation fee. But I have more data on other provinces if people would like to follow up with questions. So I think that's it in terms of all the questions that we had for tonight. I'd like to thank Dr. Ferrucci for joining us, and for everybody for spending the evening with us. There is, I think on the last slide, we had Dr. Ferrucci's email address. If you'd like to follow up and send him any questions, I'm sure he would welcome that. From my side, if you have, and then from my side, I would love questions, so it's ajones@lkc.com. Please reach out if you have any questions on the device, or reach out to Dr. Ferrucci if you have any questions on the device or the cases. So once again, thank you, Thanks again, Dr. Ferrucci, for a great presentation. Thank you, everybody else, for attending, and we hope you have a great evening. Take care.